Okay, guys, good morning. Today our topic is pneumonia. You know, it's very serious disease, and now it becomes very popular because you know that the main complication of present COVID-19 infection is a severe two-sides pneumonia, bilateral pneumonia. And actually, main cause of death of patients with COVID-19, this is severe pneumonia. So, what is it, pneumonia? Pneumonia is an infection of the pulmonary parenchyma that can be caused by various bacterial species, including mycoplasms, chlamydia, rickettsia, also viruses as COVID-19 virus, fungi, and parasites. Thus, pneumonia is not a single disease, but a group of specific infections, each with a different epidemiology, pathogenesis, clinical presentation, and clinical cause. The advent of antibiotics has decreased dramatically the mortality from pneumonia among young people, but it remains a dangerous condition. You know, before this COVID-19 infection, people believed that pneumonia, this is something benign. We have antibiotics. What's the problem? Take some tablets or injections and you recover completely. It's not the truth. You see, pneumonia is the sixth leading cause of death and the most common lethal infectious disease. Everyone, if you talk about infections, think about AIDS, viral hepatitis, Ebola, but actually number one killer among all infections, this is pneumonia. The mortality of community-acquired pneumonia ranged from less than 5% in mildly ill outpatients to somewhat greater than 12% overall in patients who are admitted to a hospital. Just imagine, 12%, 1 out of 10 died due to pneumonia if it's hospitalized. Mortality is even greater in patients who have severe invasive disease, which often is associated bacteremia, and in elderly nursing home patients. And pneumonia is a major cause of death in individuals over the age of 70. Again, we believe that actually number one cause of death, this is cardiovascular problems. But among elder people, age over 70, pneumonia becomes number one killer. So pneumonia is infection. Mechanism of infection. How a patient may be infected. This is microaspiration of oropharyngeal content. This is inhalation of small suspended aerosolized droplets. This is consequence of a bloodstream infections and penetrating chest trauma. The most common mechanism by which the lung is inoculated with pathogenic organisms is through microaspiration of oropharyngeal content, a process that occurs in otherwise healthy individuals during sleep. Colonization of the oral pharynx with pathogenic organisms such as Streptococcus pneumonia can thereby lead to delivery of sufficient quantities of organisms to infect the lung. You know, in most of cases, bacterial pneumonia, this is not actually a contagious disease because patient starts suffering from infection from his own body. This is usually infection which live in patient's oral cavity and microaspirated. Next, inhalation of small suspended aerosolized droplets. The second most frequent mechanism of lung infection is an inhalation of small suspended aerosolized droplets, which range in size from 0.5 to 1 micron and which may contain microorganisms. In view of the limited number of organisms delivered in such manner, only relatively aggressive pathogenic organisms such as Mycoplasma tuberculosis, Legionella pneumonia, Yersinia pestis, Bacilla anthrax, and some viral infections. And now, number one viral infection which may be transmitted this way, this is COVID-19. And you know why it's important to carry mask, medical mask, if you go out. Because again, for COVID-19, the main route of infection, this is an inhalation of small suspended aerosolized droplets. When actually patient, when ill person with COVID-19 coughing or just speaking or just breathing, he produces a lot of such droplets. And without mask, you can inhale all these droplets and be infected. That's why actually you know that from this day, 20th of May, in our region, it's obligatory to carry mask, medical mask and medical gloves if you go out, if you visit shops, apotheques, I don't know, bank. You must carry medical mask and gloves, and this is protection against this route of infection. No less commonly, the lung may be infected as a consequence of bloodstream infection. No, blood-borne pneumonia is seen especially in staphylococcal sepsis or right-side endocarditis, which are more common in intravenous drug uses and in gram-negative bacteremias, particularly in immunocompromised hosts. So again, infection may reach lungs with blood. No, this is not common case. The lung also may be rarely inoculated directly by penetrating chest trauma, by a local spread from nearby infected organ, for example, paragoniamiasis or amoebic liver abscess or a contagious soft tissue infection. No, this is again rare cases. Pathology. Pneumonic process may involve primarily the interstitium or the alveoli. Involvement of an entire lobe is called lobar pneumonia. When the process restricted to alveoli, contagious to bronchi, it's called bronchopneumonia. So if the whole lobe affected, this is lobar pneumonia. If it's just some focuses in lobe with affection of some lobuli, no, in this case we talk about bronchopneumonia. Cavities develop when necrotic lung tissue is discharged into communicating airways, resulting in either necrotizing pneumonia. This is multiple small cavities, each less than 2 centimeters in diameter, in one or more bronchopulmonary segmental lobes, or lung abscess, one or more cavities more than 2 centimeters in diameter. So again, pneumonia can cause destruction of lung tissue and appearance of cavities in lungs. And if this cavity is less than 2 centimeters, we talk about necrotizing pneumonia. If more than 2 centimeters, we talk about lung abscess. So, classification of pneumonia. Pneumonia can be classified both anatomically and on the base of the etiology. Classification by site, anatomical classification. Pneumonias are either localized, with the whole of one or more lobes affected, or diffuse, when the primarily affect the lobes of the lungs, often in association with the bronchi and bronchioles. The condition referred as bronchopneumonia. So if you talk about etiology, you know, among all pneumonias, about half of all pneumonias, this is due to Streptococcus pneumonia. This is mostly community-acquired pneumonias, and actually people who previously stayed home, be infected or start suffering from this disease. And again, half of all patients with pneumonia, this is the streptococcal pneumonia. What else we can have? Mycoplasma pneumonia, influenza A virus, and now of course we are talking about SARS-CoV-2 virus, because you know that that virus which caused COVID-19 is known as SARS-CoV-2 virus, and disease which is caused by this virus is COVID-19. That's why now most of people who are in hospitals with pneumonia, they have this COVID infection. Then Haemophilus influenzae, chlamydia pneumonia, Streptococcus aureus, Legionella pneumonia, and some actually less common species. You see, the whole set of microbes may finally cause pneumonia. Classification by etiology. Pneumonia, this is inflammation of lung tissue, and inflammation of lung tissue may be caused not only by infection, but also by chemical causes, No, for example, aspiration of vomit. It may be radiotherapy, some radiation which also can damage lung tissue. This is allergic mechanisms. No, actually all these mechanisms are not so common. Precipitating factors. Streptococcal pneumonia also follow viral infection with influenza or parainfluenza. You know what is the difference between, for example, pneumonia due to flu virus and pneumonia due to COVID-19 or SARS-CoV-2 virus? In case of pneumonia caused by flu virus, usually flu virus just reduce immunity, decrease immunity of the host, and as the result, then patient catch some streptococcal pneumonia infection. And this is less serious because we know how to treat streptococcus pneumonia. We can kill this germ. In case of COVID-19 pneumonia, this is virus which cause damage, and that's why it's more serious, because we still don't know how to kill this virus. Hospitalized ill patients also often infected with gram-negative organisms. No, cigarette smoking. This is strongest independent risk factor for invasive pneumococcal disease. Alcohol excess also precipitating factor for pneumonia. Bronchiectasis. This is dilatation of bronchi, also predisposed to development of pneumonia. What else? Bronchial obstruction. No, for example, carcinoma tumor, which cause obstruction of bronchi. Immunosuppression. No, for example, AIDS, HIV infection. No, in this case, we can find some specific microorganisms like pneumocysts, carini, or Mycobacterium avium intracellulare, cytomegalovirus. These microbes never cause pneumonia in patient without immunocompromising status, with normal immune system. Now, intravenous drug abuse frequently associated with Staphylococcus aureus infection. Clinical manifestation. The possibility of pneumonia should be considered if in any patient who has new respiratory symptoms, including cough, sputum production, dyspnea, particularly when these symptoms accompanied by fever or abnormalities on physical examination of the chest, such as rhonchi and rales. So again, main signs: cough, sputum production, dyspnea, fever, and pain in the chest may happen, maybe not. It depends on involvement of pleura into pathological process. You know already that no pain receptors in lungs. That's why even severe pneumonia may be presented without pain. But if we have pneumonia, inflammation nearby pleura, in case of involvement of pleura, patient may complain of pain in the chest pain. Physical examination. So initial presentation can be more subtle in patients who are elderly or have an altered immunologic status. In such patients, non-specific symptoms including loss of appetite, confusion, dehydration, worsening of symptoms or signs of other chronic illnesses, or failure to breathe may be the initial manifestation of pneumonia. Again, in elder people, temperature may remain normal because rise of temperature, this is a reaction of our immune system. In elder people with weak immune system, temperature may remain normal. And other signs like, coughing, and actually maybe not so advanced. That's why in elder people, one of symptoms just worsening of general condition, of general feeling. That's why don't forget about possibility of pneumonia in such case. Now, presenting symptoms and signs are often variable from patient to patient and can be reliably used to establish a specific microbiologic diagnosis. So what's what we're talking about? That based on clinical picture, you can't say this is streptococcal pneumonia or Staphylococcus aureus or chlamydia pneumonia cause this pneumonia. That's why clinically it's very difficult to differentiate which germ caused this infection, this pneumonia. Physical findings, classical physical findings. What we can find on physical examination? You see, after transmission of breathedowns, what we are talking about. You know, of course, that normally when you examine patient lungs and use auscultation, you should find vesicular breathing under lung fields. Classical sign of pneumonia. This is a presentation of so-called consolidation of lung tissue syndrome. What in consolidation? Lung tissue becomes solid. Normally it's air-filled. In case of pneumonia, alveoli filled with exudate, and actually lung tissue start look like as some liver, for example. Very dense and solid organ. The result of this, instead of vesicular breathing, we can find bronchial breathing. Remember, appearance of bronchial breathing. Remember, what does it mean, bronchial breathing? This is short inspiration, long expiration, and harsh sound. The harsh sound. The presence of bronchial breathing means consolidation of lung tissue, and number one cause of consolidation of lung tissue, this is pneumonia. Now, what else we can find? We can find crackles. We can find actually rales, moist rales. Crepitation. Crepitation may be found on initial and final stage of pneumonia. So-called crepitatio index and crepitatio redux. Crepitatio index and crepitatio redux. On percussion we can find dull sound on percussion under affected part of the lungs. No changes in tactile fremitus. Tactile fremitus increase because actually dense solid tissue better conductor for vibrations than normal lung tissue. So what we can do for diagnosing? Of course, we should do radiography. We should do sputum examination and serological studies. Radiography, X-ray examination, sputum examination, and serologic studies. Now, radiography. Chest radiography more sensitive than physical examination for detection of pulmonary infiltrates. Chest radiographs can confirm the presence and location of the pulmonary infiltrate, assess the extent of the pulmonary infection, detect pleural involvement, pulmonary cavitation, gauge the response to antimicrobial therapy, and high-resolution computer tomography of the lungs can improve the accuracy of diagnosing of pneumonia, especially when the process involved lungs obstructed by the diaphragm, liver, ribs, clavices, or heart. Now, everyone knows about CT scanning right now. And yes, in the whole world, number one diagnostic test to reveal this COVID-19 pneumonia, this is computer tomography. And you know, now we believe that computer tomography even more sensitive than specific PCR tests for SARS-CoV-2 infection. That's why sometimes when this SARS-CoV infection test negative, but we see on computer scanning typical picture of COVID-19 pneumonia, we diagnose COVID-19 pneumonia. And now again, this is number one test to detect this specific pneumonia. No, this is actually planned X-ray, and you can see this is big pneumonia which occupy the whole lower left lobe of patient. Pneumonia which occupy the whole left side lower lobe of lungs. Now in other pneumonia, you see, in case of pneumonia, you can see that this is some shadows in lungs. This is also pneumonia. Now in other presentation of pneumonia, tuberculosis infection, you see a lot of focuses of inflammation in lung tissue. Sputum examination. Examination of the sputum remains the mainstay of the evaluation of patients with acute bacterial pneumonia. Now, unfortunately, expectorated material is frequently contaminated by potentially pathogenic bacteria that colonize the upper respiratory tract. and sometimes the lower respiratory tract without actually causing disease. This contamination reduces the diagnostic specificity and of any lower respiratory tract specimen. So what we're talking about? Okay, to detect which germ caused pneumonia. Okay, let's collect patient's sputum. No, great, and then we'll see what bacteria can be found. But the problem is that in this sputum, we have not only content of alveoli, we have content of bronchi, we have content of larynx, we have content of oral cavity, and to understand which germs actually cause pneumonia, sometimes it's very difficult. But nevertheless, we perform these tests. Now, for example, there are different types of sputum. You see, on the this picture, you can see red blood in sputum. There are red blood in sputum, and this is result of hemoptysis. Here you can see so-called rusty red sputum in case of lobar pneumonia. Rusty red sputum in case of lobar pneumonia. Now, actually, this is a histological picture of interstitial pneumonia. You see, this is alveoli, and everything is filled with actually neutrophils, other cells, so producing this infiltration and histological picture of interstitial pneumonia. Also, we classify pneumonia based on clinical signs. So we talk about community-acquired pneumonia, nosocomial pneumonia, or hospital pneumonia, and aspiration pneumonia. So community-acquired pneumonia, it means that patient catch this disease or caught this disease staying outside of hospital, somewhere in community. Now, usually we talk that there are two syndromes of community-acquired pneumonia, typical presentation, atypical presentation. Now, current data suggests that these two syndromes may be less distinct than was one thought, and the characteristic of the clinical presentation may nevertheless have some diagnostic value. So in case of typical pneumonia syndrome characterized by sudden onset of fever, cough production of purulent sputum, shortness of breath, sometimes pleuritic chest pain, no signs of pulmonary consolidation, again dullness on percussion, increased tactile fremitus, egophony, bronchial breathouts, rales, may be found on physical examination areas of radiographic abnormality. So this clinical, typical presentation, typical picture of pneumonia, and very easy to find correct diagnosis. In this case, we talk about typical pneumonia. Now, typical pneumonia syndrome usually caused by most common bacterial pathogen in community-acquired pneumonia. This is Streptococcus pneumonia, but can also be due to other bacterial pathogens such as Haemophilus influenza, mixed anaerobic, aerobic components of oral flora. Atypical pneumonia syndrome characterized by more gradual onset, dry cough, shortness of breath, prominence of extrapulmonary symptoms such as headache, myalgia, fatigue, sore throat, nausea, vomiting, diarrhea, and abnormalities on chest radiographs despite minimal signs of pulmonary involvement, other than rales on physical examination. Now, atypical pneumonia classically produced by Mycoplasma pneumonia, Legionella pneumonia, chlamydia pneumonia. Now, actually, clinically, we use sometimes terms typical pneumonia, atypical pneumonia. Да? And mostly this is not due to actually clinical presentation. This is due to microbes. We have typical microbes like actually Streptococcus pneumonia, and we have atypical microbes like again Legionella pneumonia or chlamydia pneumonia. Nosocomial pneumonia or hospital pneumonia. What does it mean? This is pneumonia which happened when patients stay in hospital for other reasons, not with pneumonia. For example, he had treated his, cholecystitis or pancreatitis or heart disease, and patients with nosocomial pneumonia often pose a diagnostic challenge. The differential diagnosis of acute respiratory disease in critically ill hospitalized patients is diverse and includes non-infectious entities such as congestive heart failure, acute respiratory distress syndrome, pre-existing lung disease that may be difficult to distinguish clinically or radiographically from pneumonia. The usual criteria for nosocomial pneumonia, which include new or progressive pulmonary infiltrates, purulent tracheobronchial secretions, fever, leukocytosis, and frequently unreliable in these patients who often have pre-existing pulmonary disease in the tracheal tubes and that irritate tracheal mucosa that may elicit an inflammatory exudate in respiratory secretions or multiple other problems likely to produce fever and leukocytosis. So what we are talking about? On one hand, patient already in the hospital. No, it's patient every day examined by doctor. So it looks like it's very easy to find pneumonia. But problem is that patient already present a lot of signs. Patient already may have fever due to, cholecystitis. Patient already may present with coughing due to heart failure and congestion of blood in lungs. And that's why to find out new signs, sometimes very difficult. And patient with nosocomial pneumonia complicating an underlying illness associated with significant neutropenia often have no purulent respiratory tract secretions or pulmonary infiltrates. And patient with nosocomial pneumonia complicating uremia or cirrhosis often remain afebrile. So again, if patient in hospital already, problem is he presents a lot of signs, and to find new signs due to pneumonia sometimes is a big challenge. No, patients at great risk for nosocomial pneumonia are most likely to be heavily colonized with potential pulmonary pathogens in the oropharyngeal tracheobronchial mucosa. Thus, the presence of this organism in gram-strained preparations or cultures of respiratory tract secretions doesn't necessarily confirm the diagnosis of pneumonia. Yeah? So, one more thing about nosocomial pneumonia. Problem is that in hospitals we have much more aggressive germs. Remember I told you that in community usually this is Streptococcus pneumonia and it's good. Why it's good? Because Streptococcus pneumonia is very weak germ. It's a very, very weak germ. We can treat this microbe using even penicillin, which was found 80 years ago. And actually normal simple antibiotics can easily kill this pneumococcal infection. If we talk about actually hospital pneumonia, this is usually gram-negative flora. This is very aggressive germs. This is germs which survived under attacks of different antibiotics. And that's why this infection much more difficult to treat. And we use even other antibiotics when we treat patients with nosocomial or hospital pneumonia compared with patients who presented with community-acquired pneumonia. That's why, again, so high risk of death in patients with hospitalized pneumonia. Now, generally, I may say that pneumonia, this is final shoot of the patient. Because usually who die from pneumonia? Patients already suffering from very serious disorders. Cardiovascular, cancer, immunocompromising disorders. Even in case of HIV infection, what is the real cause of death of patients with HIV infection? In most cases, this is again pneumonia. Which finally kill persons, finally kill these persons. So, actually, again, what you should remember, pneumonia is still very important disease, it's still very serious disease, and now, when we have this epidemic of COVID-19 infection, we can see that pneumonia is still extremely dangerous disease. And what we can do is to identify this disease and try to do something to prevent severe consequences. If it's bacterial pneumonia, we know what to do. We have antibiotics. If it's viral pneumonia, like what we have now, COVID-19, we use some remedies. Which were used to treat HIV infection, which were used to treat malaria. Actually, no good remedy to kill this virus still now. That's why Only one thing to prevent. This is isolation. Isolation. This is air-based infection. This is infection spread from person to person. That's why please stay at home. If you leave home, please carry actually medical mask, gloves, protect yourself, and this is only one way to avoid this contamination. Okay, if you do all this, no, don't worry. Actually, for young people, usually this infection is not so serious. Young people rarely present it with pneumonia. They usually present it as some actually acute respiratory viral infection with just a slight rise of temperature or nausea or just sore throat or something like this. But nevertheless, again, be careful. Okay, if you have some questions, you can type these questions in the chat, or just type that everything is clear. Just write that everything is clear. Everything is clear. Waiting for your questions. Waiting for your questions. Okay. If everything clear, the lecture is over for today. So again, take care about yourself and good luck. See you next week.